Frequency Podcast Network. Stories that matter, podcasts that resonate.
You know the phrase by now. It's uttered by everyone, from politicians who are after your vote, to your fellow citizens suffering from sheer frustration, or even just comics looking for a laugh.
After 9 years of this prime minister, everything is broken.
Everything's broken. Everything feels broken.
Everything feels broken.
But when he says that Canada is broken, that's where we draw the line.
In the ERs that remain open, wait times have never been longer.
It may seem like there's a lot of places to shop in Canada, but all these stores are owned by just 3 big companies.
There's extreme partisanship and extreme polarization.
A new poll says that the majority of Canadians feel that Canada is broken. What? Just because the stock market is down, the railroad is on fire, and the Leafs lost to a Zamboni driver?
We're going to let Justin Trudeau and Pierre Poilievre argue over if this country is entirely broken or not. But as we cover the news in Canada, it has become very clear to us here at The Big Story that some of the systems we rely on are faltering, to say the least. And rather than use that to try and grab some downloads or score a few political points, we thought we'd ask some of the smartest people in their respective fields a few simple questions. Starting with this: is it broken? If it is, how do we fix it? Welcome to Fixing Canada, a special series running all this week on The Big Story. Today, healthcare, where the crisis can be literally life or death. It's been 4 years now since the pandemic hit. During that time, we have heard about the strain on every part of our healthcare system. From overcrowded hospitals to closed emergency rooms, vanishing family doctors, incredibly long wait times, an increase in private clinics charging us for services. Despite the hard work of tens of thousands, it's clear there aren't many aspects of universal healthcare really working well for Canadians. But what if we looked at that as an opportunity, rather than a gaping hole to be filled with billions of dollars of taxpayer money? I'm not trying to save you a few bucks here. I'm asking, what if the current state of the healthcare system gives us no option but to reimagine the entire thing, to change who does what, with whom and how and where, and create the kind of collaborative healthcare system that gets the most out of what we have, rather than demanding money for fixes that never seem to result in different outcomes for many patients? What if, instead of fixing the current healthcare system, we just make a new one? I'm Jordan Heath Rawlings. This is Fixing Canada on The Big Story. Dr. Alika Lafontaine is the former president of the Canadian Medical Association, an award-winning physician, and the first Indigenous doctor listed in Medical Post's 50 Most Powerful Doctors. Also pertinent, beyond all that, to this conversation is he contributed to a public policy forum report last year that looked at ways we could possibly find solutions to the healthcare crisis. That's a tall order right now, Dr. Lafontaine.
I think for anyone using the healthcare system, they definitely agree.
I will ask this because I think everybody might have their own opinion of it, but I think everybody knows right now the system is broken, if you want to call it that, in crisis, whatever term you want to use. But if our healthcare system is indeed broken, when did it break, as best you would ballpark it?
I think people get drawn towards these ideas that we can find specific moments in time where if only we made one different decision, things would have been better. The healthcare system is obviously one of the most complex systems that we use in society. And as part of that, there's multiple different things that broke. I think if I was to go back in time and look at when did decisions start going south, when did we start choosing to go in directions with the healthcare system that eventually led to the place that we're in right now. I'd probably look back to the 1990s. So in the 1990s, there was that era of federal budget cuts and decentralization. There were strained provincial budgets. People were looking at places where they could save money. And as part of that, there was aggressive cuts that were made to healthcare and a shift in focus from having people have access to having things cost as less as possible. Now, as that kind of spread throughout Canada and we started having reports that started to recommend different changes, different systems across the country started to shift their view on how healthcare systems were supposed to work away from focusing on patients and the people working in it to simply focusing on money in it. I think that's really the root of where all these problems happen. Now, in the meantime, we've had shifts in demographics. People are much more sick. I can tell you that as somebody who works in the healthcare system. People who walk through our doors are much more complex. People are hypermobile, which means that you don't just live in the same place for 40, 50 years anymore. You travel across the country, sometimes across provinces and other jurisdictions, trying to access care. And our health workforce is very mobile as well. So all those things together have led to things breaking. But I think you go back to the 90s and find the origin.
I don't want to spend too much time on the problems here because I want to talk to you about solutions. But when we try to diagnose what's wrong with the healthcare system today, what is the best criteria for measuring how well the system is or isn't working? Is it wait times that are often discussed? Is it the number of people with or without family doctors? How do we diagnose the system as if it were a patient?
I think the framing of that question is really effective. Asking if this was a patient, how would you diagnose them? So for folks who practice medicine, one of the things you realize over time is that diagnoses are not black and white. You make an educated guess on what's happening, and you create a list of plausible things that could be happening. And over time, you try and investigate and produce additional evidence or data, and then you test out your theories based on what should fix those problems. And I think if we're diagnosing what's wrong with the healthcare system, one of the biggest problems is that people are fixated on money being the problem. When in reality, I think it's identifying value. And if we were to diagnose and then find solutions, the solutions that I'd focus on would be how can we get as much of value out of what we do in the healthcare system, but also how do we make sure that value isn't just the value of people who make decisions in the healthcare system. An administrator will look at what I do. I was on call last night, and there was a lot of time that I spent going through patient charts and talking with folks about what was going on throughout the night. I practice as an anesthesiologist. Administrators might look at what I was doing and say, you're being extremely inefficient with what you're doing. But there's a lot of relationship building. There's a lot of time that you need in order to let ideas kind of steep. You can't just rush through providing care like it's an assembly line. And I think that's a big problem that we have in healthcare right now.
How do we find where the value can be created? And if a bookkeeper were to look at what you did and say it was inefficient, but it really was working for you, what is an inefficient use of our time in the system right now that we could fix?
I think there are things that we can categorize as clearly not providing value. And I think a lot of the value has to be focused on when a person walks through your door, whether it's through an emergency room or a clinic or some other place, do they walk away with a clear idea of what they need to do to make their problem better? And at times, do they actually have their problem solved? I think there's a lot of things that we do in healthcare where people have touch points in the system, but they don't really get what they need. How many folks do you need to talk to before you find one who's gone to multiple different people within the healthcare system and still does not have a clear idea of exactly what they need to do next?
How do you fix that, though?
I think we ask patients. We talk a lot about having these learning systems where we have ideas on how to fix things. We try and fix them. They work, they don't work. We circle back and do research and collect other data, and then we try again. But what really happens in the healthcare system is people have these ideological ways of approaching things. Things should cost as little as possible. We should have as few moments of downtime as possible in the day, et cetera, et cetera. Instead of actually asking, is what you're doing for the patient, having them walk away with a better experience. And I think this is a big shift that needs to happen in medicine, where we move from this volume cost model towards actually asking people, do you get what you need from the encounter that you just had?
And how can we find ways so that more of physicians' time or nurses' time is spent directly communicating with patients and with other doctors about solutions to their problems and less shuffling them between people? Like, I guess what I'm trying to understand is, where can we cut down on the steps a patient has to go through in order to get that final diagnosis?
A lot of the weight of having to figure out the answer to that question lies on the shoulders of patients. And in well-functioning systems across the world, that weight is actually shifted to the system itself. If you have abdominal pain, for example, you walk through a door and you say, I know that my stomach hurts. I don't know why. This is how long it's been going on. These are the other associated symptoms. The person across from you probably has a much better idea of where you need to go to get that problem assessed and possibly treated than yourself. But what do we ask patients to do? We ask them to go through door after door after door until they find the person sitting across the table who can solve their problem. And I think that this is the power of team-based care. And if we were able to move towards a system where the person across from you was both incentivized and it was culturally normal for them to take your problem and shepherd it through the system, I think you'd get exactly what we're talking about here.
How much of that change is possible when, and you would probably have firsthand experience with this, the system is already so overburdened and overtaxed, and we hear all the time about doctors and nurses stepping back from the profession because of burnout. And now, to provide better care, we're going to say, okay, we need to take more time. We need to gather as a team. We need to, really focus on this. And how much time do you have for that in a day anyway?
I would separate burnout between hard things and things that, for lack of a better word, kill your soul. We're used to doing hard things in medicine. We're used to being in complex, high acuity, highly emotional situations where, life and death often hangs in the balance. That is not the exhausting part of medicine. The exhausting part of medicine is trying to do the right thing for patients and having the system continually push back against getting your patients the care that they need because of red tape, because of folks who are just not focused on patient problems, but are instead focused on system problems, folks not responding to increases in resources that they've known have been needed for time after time, seeing the same problem over and over again and not getting a response or action that actually fixes anything. The pandering that happens quite commonly across medicine, or taking a real problem and reshaping it into something that ends up getting politicized. These are the things that really exhaust providers within the system. And I think in the same way, patients who are involved in this get pretty exhausted as well. So when you look at how a person spends their day in medicine providing care, if we were to measure the impact that they had on patients' lives throughout the day and then tried to simplify their ability to have that impact, we'd have a very well-functioning system. And, the interesting thing about making that statement is that's how all systems work. And so when we talk about healthcare and people not being able to spend their time on the right things, it's because the system's been designed to solve problems that are no longer the problems that are facing the people trying to provide and access care in the system anymore.
Give me a sense of what that looks like on the ground, like a problem the system was designed to solve that you don't see anymore, and one that you're struggling to solve now because the system's not ready for it.
So I'll give a broad category of administrative burden. This is something that you hear commonly from our primary care providers, especially family physicians. When you talk about something that has drawn the life and joy out of practicing family medicine, administrative burden is probably one of the highest things. So a person walks through your door, they have a disability. And as a result, the forms that they're asked to fill out require a family physician to sit down for a very long period of time to fill out several pages of forms. And the first question is, why is the family physician filling out that form in the first place? There's probably no specific expertise required for that form to have the family physician put in place. So it's really just a speed bump in order to make sure that that patient across from you has a more difficult time getting their disability than actually solving any problems. And so, there's lots of other examples that I could come up with that reflect that. But anytime you have something in the system where you need to do something and it doesn't seem like there's a whole lot of value to doing it, or it seems like the only reason why it was put in there was to make it harder to do, that's the administrative red tape we have to get rid of.
That's a great example. And it leads into what I want to ask you about both the Public Policy Forum report that you contributed to, and then also a recent CD Howe report that I gather you looked at as part of your work with the CMA. And one of the things that both those reports contained were examples of some recent steps that we've made in terms of improving in various places across the country. The access to those kind of foundational programs of medicine. Can you give us a few of those that have caught your eye and made you think, like, if we could do this everywhere at scale, it would really work?
I think there's quite a few things that could be done to fix medicine right now. And there are actually a lot of things that we know work, but we have yet to do at scale, or we do at scale, but because of cost, we draw back and stop doing them. So we obviously need to change the way that teams work together. We often talk about team-based care as the way that we create a future-proof healthcare system. But creating an environment where you can have more than one type of provider work together. Team-based care is not a bunch of doctors working together. It's not a bunch of nurse practitioners working together. It's everybody working together. In those teams, you end up having a growth in perspective. You end up having a shift in skill set because you're getting exposed to people and ways of thinking that you didn't consider before. So team-based care and taking that role from the patient, like I mentioned before, to navigate the system and putting it on the shoulders of the team instead, I think is one of the most effective ways to improve health outcomes, but then also to decrease system costs over the period of life of the patient. Other interventions are things like decreasing administrative burden, moving towards licensure where you don't have to register in each one of our 13 provinces and territories separately, moving towards outcome-based healthcare, where we're not looking at how much money we could save as the primary output, but instead looking at, do people actually get better as a result of what we're doing? These and other things are issues and solutions that we've talked about for years, but we just haven't implemented. And I think both the reports really emphasize that the time for talk has passed. We have to move towards action if we want to fix our healthcare system.
You just touched on something that I want to explore a little bit more, because we've covered healthcare a lot on this show. And one of the things that always comes up is how it's like this in Ontario, but not in British Columbia, how it's so much more challenging, obviously, to deliver healthcare in the Northern Territories. I know right now in Quebec, there is a big debate over delivering healthcare in French to English patients and how they navigate that. How do you reform a system that is implemented 13 different ways? Like, explain the logistics that have to happen there.
One of the ongoing myths about healthcare reform is that Canada's federated system is part of the solution. What I mean by that is we look at countries like Denmark, for example, and we often focus on how great it is that you could go into a city in Denmark and automatically be registered with a family physician, and your wait times are shorter than Canada, the administrative costs are lower. But Denmark does not, as a country, have multiple different jurisdictions that push back at each other when it comes to system-wide reform. And when you look back at big shifts in the healthcare system in Canada, particularly the creation and passage of the Canada Health Act back in 1982, the real power of that legislation was not in forcing the different jurisdictions to work together, but in creating a shared vision that everyone can start to focus on the same sorts of problems and create shared approaches. I've been active in healthcare leadership for almost 2 decades now. I've done system change at a clinic level all the way up to nationwide and international. And I will tell you, after all that experience, the issues that each province and territory has is not so unique that we need our own unique plans and approaches to them. That is a myth that we continue to tell Canadians, and it lies at the root for not solving a lot of the big problems that we have.
If we could all get on the same page about these are the issues, these are approaches we can take, and at least try to move things forward and, adjust based on results as we've discussed. Is all of that enough given the actual losses the system has experienced, particularly over the last 5 years or so? You can find efficiencies, you can change approaches, you can create team-based medicine. At some point, though, we still just don't have enough doctors or nurses, right? How do we solve that?
So I don't think we actually will. But what I mean by that is that we can't go back to the way the system used to work. And I think that's a hanging thread that people continue to grab onto, that somehow if we make this change or that change, we'll go back to the early 2000s when things felt better. Or go back to the 1960s where we could just open a new clinic and provide new access, and there would be plentiful health human resources and equipment and money and other things to provide that sort of access to patients. We have to evolve for the world that we're in right now. And what is the world that we're in right now? It's a world that's hypermobile. It's a world where people want care where they are. And it's a world where we have limited health resources, money, equipment, and space. And if we were to build for that world, we would be less focused on increasing numbers, which we do need to do, but that's not going to be the end solution. And instead, changing how we work together, changing the way that we compensate folks who provide care, but then also track whether or not patients are getting what they need out of care. We would shift our focus from how can I create an approach in this province or jurisdiction to how can I see how patients move throughout my province and other provinces and territories that may be nearby. An example being Alberta, the Yukon and Northwest Territories has a lot of movement back and forth, especially along the borders between our 3 jurisdictions. And figure out how can I share information, how can I share personnel, how can I share access, so we can decrease the amount of touch points that people need to have in a healthcare system that really needs to have things happen in the most effective and efficient way as possible. You take the place that I live, Grand Prairie. It's along the border of BC, about an hour and a half away are multiple different towns, including a place called Fort St. John. There's been a lot of situations where I have had patients from BC come to receive care at our larger center, and I've had to repeat investigations, exams. I haven't been able to access consults. I've been asking the patient about things that they remember from their care, but of course that memory is incomplete, or people may have not told them what actually went on. I can't access any of those sorts of records. That's the kind of efficiency that we need to get rid of, but we will never get rid of that as long as we keep this jurisdictional model in our head, that somehow the solution is rooted in doing things the way that we always have.
Who do we need to get on board to make that profound shift? Who are the key stakeholders here that if these 5, 10 people or organizations bought into it, this would become less of a theoretical thing we're discussing here and more of a we're changing the healthcare system?
So change always happens on the ground, but the rules by which change happens is 100% in the hands of the government. And so we can unleash innovation if we get clarity from government on the innovation that we're actually trying to unleash. If you had 13 jurisdictions sit down and say together, we're going to figure out mobility of health providers. We're going to figure out how to have care designed around how people move throughout the system versus building a place and forcing people to go there. You would end up having folks within the system sit down and say, okay, I know 100 different ways of doing this. And then you'd have groups of people come together and say, out of these 100 ways, this would be the lowest cost. This would maximize our resource to impact. This would be the easiest way for patients to access things. This would give the best experience. But what we lack right now in Canada is what we needed in 1982. We needed a new vision. We needed folks to come together and say, this is actually the kind of healthcare system that we want to build. And in the absence of that, we'll continue to see a degradation of healthcare services. And like we said at the beginning of this conversation, a collapse of healthcare.
This is my last question then. Is there a tipping point, or maybe it's not a tipping point, maybe it's just a cliff at which we will have to change the way we approach how we do this, whether we want to or not? One of the themes that we're hearing a lot of during this week is that, big, profound change is difficult, especially in such a large country, and we often don't do it until we absolutely, absolutely have no other choice. So I guess, I'm asking you, what does that point look like?
I think we've passed the tipping point already. When you have emergency rooms shutting down across the country, when you have 1 or 2 decisions shut down surgical capacity at a hospital for weeks at a time, when you have providers like in Quebec leaving the public system to work privately, we have passed the tipping point. Now, the question is, in the broader landscape of crises that we're addressing, and there's lots of crises going on in the world, at what point does the collapse of healthcare rise to a level where it becomes the priority? And we saw healthcare become the priority, from 2020 until 2023, when the pandemic overwhelmed healthcare systems and things that we took for granted started to fall apart. Everyone put on the brakes to what they were doing and focused solely on healthcare. Now, it is frustrating that a lot of the things that we learned and implemented successfully then, we let fall to the wayside. We don't have jurisdictions working closely together like they did before. But I think that the tipping point has been passed, and the real question is whether healthcare will be made a priority or not. Folks don't remember what healthcare was like in the 1940s and 1930s. Before there was organized systems of care like we had now, healthcare really was a mishmash of nonprofit, charitable, and private institutions with very little public funding. And as a result, people suffered. Medicare was created because in Saskatchewan, they had an existential crisis. Folks were getting sick. They were going into the hospital. They were unable to pay. So they went to the charitable part and they just never got back out and never ended up becoming a part of being productive anymore in Saskatchewan society. And so as a result, the government was forced to create a system where people could receive care without having to worry about going bankrupt. Bankruptcy's number one reason in the United States is healthcare. So if we don't fix this, that is the future that we are going to be moving towards. And I think we're past the tipping point of not being able to go back. But if we continue to deprioritize healthcare, that is our future. That is the future I fear.
Dr. LaFontaine, thank you so much for this. It's a really insightful diagnosis, to use that term again, of where we're at right now.
Thanks for having me.
Dr. Alika Lafontaine is the former president of the Canadian Medical Association and, as you heard, a practicing physician. That was The Big Story. For more from us, including all the rest of this week's episodes on how to fix Canada, you can head to thebigstorypodcast.ca. You can also send us feedback on any of these episodes with an email to hello@thebigstorypodcast.ca or a phone call and a voicemail at 416-935-5935. The Big Story's in every podcast player and on every smart speaker. You just need to ask it to play the Big Story podcast. Thanks for listening. I'm Jordan Heath Rawlings. We'll talk tomorrow.